Okay, so recording has started. Okay. Okay, which of the following cells have the same embryologic region as the tissue responsible for this patient current condition? Okay, after reading the last line, then you will see the options for 1 second. Okay, then we will start reading from the top of the question and first try to make diagnosis here. Okay, let's start. A 33-year-old man comes to the office. Okay, let's see what are the signs and symptoms here. Episodic headaches accompanied by sweating, feeling of anxiety that spontaneously resolve after 15 to 30 minutes. Okay, episodic headaches, sweating, and feelings of anxiety that spontaneously resolve after 15 to 30 minutes. Okay, other than that, no other medical condition, no medication. His brother recently had surgery to treat hyperparathyroidism. Okay. Blood pressure is 180 by 110. Okay. Normal serum electrolytes and renal function. CT scan of the abdomen reveals a mass in the right adrenal gland. Right adrenal gland. So, do you know any type of disease which is involved with the mass in the right adrenal gland? And the symptoms are episodic headache, episodic sweating, hypertension, and anxiety symptoms, which are episodic. And that,
Pheochromocytoma.
yes. And the another clue in this question
Yes.
is his brother had a surgery to treat hyperparathyroidism. Why the examiner has wrote this line in this question? His
Autoimmune.
Men to A.
Meant to.
Rule of
Yeah,
men to.
to show
Running
us
in the
that it
family.
is something related to multiple endocrine neoplasias. Okay, and in which men syndrome there is hyperparathyroidism and pheochromocytoma.
To A.
Men to A.
2A.
Men 2A. Okay, so the most likely the patient has men 2A. Okay, it is a genetic condition in which the patient has pheochromocytoma and okay, pheochromocytoma. Okay, pheochromocytoma arises from where? Adrenal cortex or adrenal medulla?
Medulla.
Medulla. Medulla.
Medulla. Okay, adrenal medulla. Okay, see. First, see the men 2A, parathyroid, medullary thyroid carcinoma, and pheochromocytoma. Okay. Okay, let's open pheochromocytoma. Most commonly arises from the adrenal medulla. And adrenal medulla arises from what embryological cells? Does it arises from ectoderm, mesoderm, endoderm, or what cells?
Neural crest cells.
Neural crest.
Neural
Ectoderm.
crest cells. It derived from chromaffin cells from neural crest cells. Okay, you can see the symptoms here. Episodic. Remember, the symptoms of pheochromocytoma will always be episodic. Pressure, pain, palpitations. Okay, the patient has a elevated blood pressure, elevated. The patient had headache, sweating, tachycardia, palpitations. Okay, all of these symptoms are present. Okay, so the cases of pheochromocytoma and pheochromocytoma arises from neural crest cells. Now we have to tell him what other cells also arises from neural crest cells. Okay,
Melanin.
melanin producing cells also arises from neural crest cells.
Yes.
Cardiac cell cancer.
Okay, let's see. Switch is written in embryo or people remember with the yes. Okay, you can see the cells which arises from Neural crest cell. And neural crest cells arises from where? It is a part of ectoderm. Okay, these are the cells which arises from neural crest cells. Adrenal medulla, adrenal medulla, melanocytes, PNS ganglia, adenoblast, enterochromaffin cells, Schwann cells, spiral membrane, skull bones. Okay, read these all of these. Now, if you now tell me which one is a which option has either of these. Okay. Okay. Our options are capillary endothelial cells, cardiac myocytes, interstitial fibroblasts, melanin producing cells, and thyroid follicle cells. Which one is going to be the right answer?
C.
D. Melanin producing cells. You can clearly see melanocytes. Okay. PNS ganglia, there is a mnemonic as well, eomopasses, okay, which will help you to remember all the cells which arises from neural crests. Okay, let's move on to the next question. Okay, let's move on to the next question. Which of the following hormonal changes are most likely to occur during the course of study? See the options, now see the question. 50 obese adults without diabetic mellitus are enrolled in a 10-week weight loss program. The program includes a weight loss, includes a low-calorie diet, moderate intensity exercise for at least 150 minutes per week. The study subjects who are adherent to the regimen lost an average of 7 kg at the end of 10 weeks. Okay, they have lost 7 kg at the end of 10 weeks. Venous blood samples to study biochemical changes induced by weight loss are taken at the start of the trial and at the end of this trial. Okay. Which of the following are like, okay, so he is asking when the patient has lost 10 kg, 7 kg, what hormonal changes, what hormonal change differences are going to be present when the patient is at the when you made the ghrelin at the start of the study and then at the end of the study, whether that ghrelin will be high or low, whether the leptin is going to be high or low, whether the insulin is going to be high or low. Okay, at high at high BMI, at high weight of the body, what is the insulin resistance is going to be high or low? When
High.
the weight of insulin, okay, when the insulin resistance is high, does the body will produces more insulin to compensate for this to compensate for that insulin resistance or less?
More.
Low. Less.
More. Yes. Yeah, the body will produce more insulin to compensate for that insulin resistance. Now the body weight has dropped. Okay. Now when the body weight has dropped, the insulin resistance is also going to be less as compared to when the patient has 7 kg more, right? So insulin resistance has dropped. So now the body will produce more insulin or less insulin?
Less.
Less
Less.
compared to the
Okay.
placebo.
Yes. Okay. Good. Okay. So it's option C, option D are eliminated. Okay. Now comes to option number A and B. Okay. Leptin. Leptin is produced by what? Is produced in what cells? Leptin is produced by
Adipose.
Fat
lipid
cells.
cells, by the
Adipose.
fat cells, right?
Fat cells.
A, and leptin function is to decrease the appetite, right? Okay. So so greater your number of fat cells, greater is the amount of leptin production. Okay, now when you have lost 7 kg, leptin is going to be low.
Decrease.
Okay, leptin is going to be decreased. Okay,
Decrease.
yes, it is going to be decreased. So let's open. It is also written in your endocrinology. Ghrelin, leptin. Okay, you can see here leptin and ghrelin. Leptin is a satiety hormone produced by adipose tissue. Okay, obese patient have increased leptin due to increased. Okay, so greater is your number of adipose tissue, greater is your number of leptin produced. When you drop 7 kgs, adipose tissue is going to drop and leptin is also going to drop. Now see ghrelin. Ghrelin stimulates hunger, okay, produced by stomach, fasting, and sleep deprivation, fasting, or Prader-Willi syndrome increases ghrelin. But ghrelin makes you grow hungry. Okay, so when you do fasting and lost a 7 kg, the ghrelin is going to be increased or decreased. What will happen to the
Increase.
ghrelin?
Increase.
Increase.
Ghrelin is going to be increased. Okay, ghrelin stimulates hunger, and the leptin depresses the hunger. Okay, ghrelin is a fasting is the one which increases which stimulates the appetite and promotes weight gain, and leptin is the one which decreases the appetite. Caloric restriction increase the leptin, decreases the insulin and leptin levels. Let's move on to the next one. The polypeptide segment containing the mutation is most likely to undergo which of the following processes within the
Sir, can you please
pancreas?
repeat about the insulin? Why insulin is decreasing?
Because when the weight is high, the insulin resistance is going to be high. And when the resistance is high, the body has to produce much more insulin to compensate for that insulin to generate a similar response. Now, when the body weight is dropped, the insulin resistance is also dropped, and the body has to produce less insulin to generate the same response. Okay, that's why the insulin is low. Okay, when the weight has dropped. Am I being clear? Did you able to understand the concept?
Yes, sir.
Okay, let's move on to the next one. The polypeptide segment containing the mutation is most likely to undergo which of the following within the pancreatic beta cells. Okay, see the cross options. Okay. Researchers studying the pathophysiology of diabetes mellitus identify a family with an inheriting mutation in the insulin gene. Okay, they had a mutation in the insulin. Results in a single molecule in the proinsulin molecule of the way symptomatic completely. Okay. However, affected may the mutation results in a substitution the pro-insulin molecule. However, affected family members are asymptomatic. Okay, affected family members are asymptomatic, and most have normal blood glucose level even after the mutation. Analysis of the mature insulin molecule shows that it is identical to the normal human insulin. Okay, the researchers conclude that the amino acid affect a segment of removed during post-translational processing of the protein. Okay, and the polypeptide segment containing the mutation is most likely to undergo which of the following processes within the pancreatic beta cells. degradation in lysosome, proteasome, degradation in the rapid translocation across the plasmic. Okay, insulin, a pro-insulin is equal to pro-insulin.
Insulin plus C peptide.
Insulin plus C peptide. Okay, so see, this is the pro-insulin. It has insulin plus C peptide. In the question, he has mentioned that there is a mutation in the pro-insulin molecule. Okay, and the pro-insulin converts into insulin plus C peptide. It breaks down into insulin plus C peptide. Okay, so when they checked the insulin, there is no mutation in the insulin. I'm not talking about pro-insulin right now. I'm talking about insulin molecule only, the yellow molecule here. The mutation is not in the insulin molecule. What does that mean? That the mutation which is in the pro-insulin is transferred to what area? It is in
C-peptide.
the it is in the
C-peptide.
C-peptide area. That's why even when there is a mutation in the whole proinsulin molecule, the location of that mutation is is in that area which is going to convert into C-peptide, not in the not in the insulin. Okay, that's why the insulin molecule is normal and the patient is showing a normal glucose levels. Okay, and we know what happens to the C-peptides. They are secreted along with insulin into the bloodstream. That's how we made the insulin. That's how we made that the insulin is endogenous. Okay, because C peptide is secreted along with insulin. Okay, it is cleaved from the insulin, but it is secreted in the same secretory molecule as the insulin. Okay. Okay. First there is pre-proinsulin, which is synthesized in the endoplasmic reticulum, and then is the cleavage of pre-signal, and then it is converted into proinsulin. Okay, this is happening in the RER from pre-proinsulin to proinsulin. Okay, now there is going to be, and it is going to be stored in the secretory granules. Now we are in the secretory granules, not in the rough endoplasmic reticulum. Okay. Okay, now there is going to be cleavage of the proinsulin, and there is the exocytosis of insulin plus C peptide. Okay, so which one is going to be the right answer here? Which one is going to be the right answer here?
E.
Look like E because there
Stored
is
in the
the
secretory granules.
bridge of
Yes, because it is going to be because insulin and C peptides are in the secretory molecules. Pre-proinsulin is in the rough endoplasmic reticulum, okay, which is then converted into proinsulin and that is transferred into the Golgi apparatus where it is released as where it is again cleavaged into a C peptide plus insulin in the same secretory granule. Okay, it is going to be stored in the secretory granule. Okay, it does not directly it does not be directly translocated across the plasma membrane. It is not it is not degraded in the lysosome or proteasome. Okay, so see this process. There's pre-proinsulin which is converted into proinsulin. Okay, and that proinsulin is cleaved into a C peptide plus insulin in the secretory granules, and eventually both are released into the bloodstream. Which of the following is responsible for this patient's symptoms when exercising? A 46-year-old man develops episodes of dizzy spells, okay, dizzy spells, okay, accompanied by palpitation and sweating during the exercise palpitation and sweating on dizzy episodes, okay. His symptoms improve after drinking orange juice or eating a protein bar. Okay. Okay. Was diagnosed with type 2 diabetes 6 months ago and advised to lose weight with dietary modification and exercise. Since then, he has been working out intensively and has lost 10 kg. Which of the following mechanism is responsible for this patient's symptoms when exercising? Which of the okay, okay, so these symptoms are of what? Dizzy episodes, palpitation, and sweating, and the episodes improve after orange juice.
Hypoglycemia.
These are the symptoms of hypoglycemia. Okay, can you tell me which GLUT receptors are activated by insulin?
GLUT4.
Bullet 4.
GLUT4.
GLUT4
Are
are
the
the,
muscle cells.
okay,
Yes.
yes, GLUT4 are the receptors which are activated by the insulin. Okay. See symptoms of hypoglycemia, lethargy, syncope, and resolution of Whipple's triad. We call it Whipple triad. Low blood glucose and normalization of plasma glucose levels eh, after eating something. Okay. Okay. Now comes to the GLUT receptors. So we are sure that it is hypoglycemia symptoms, right?
Yes.
Yes. Okay. Now comes to the GLUT receptors. Insulin dependent glucose transporter is GLUT4. Okay. Exercise can also increases the GLUT4 expression. Okay. And GLUT4 is present in adipose tissue and striated muscles. Okay. So the patient is seeing hypoglycemia episode during the exercise. Okay, because there will, the most likely mechanism is that the insulin is going to increase the GLUT4 expression, and through GLUT4 receptors the glucose moves inside the muscles, and due to which the patient is showing signs of hypoglycemia.
Hypoglycemia.
Okay. Okay, GLUT4 is not the answer, GLUT2 is not the answer. So what is going to be the answer here?
Glut 4.
glut
E.
GLUT4. Exercise can also increase GLUT4 expression. Okay. Insulin dependent glucose transporter. Okay.
Dr. Asnan, can we discuss the other options also? What's wrong, little bit detail. The wrong answers,
Okay, but they are
We have a
most,
time, Sorry.
okay. Decreased hepatic glucose production. Insulin decreases the gluconeogenesis or glycogenolysis, or increases it?
Increases it.
Increases it.
So
Okay.
option, it seems option is mechanism of action of metformin. Decrease hepatic glucose.
Yes, it's function of glucagon.
Yes, it is. It is the function of glucagon. Okay, as glucagon and epinephrine stimulates the hepatic glycogenolysis and gluconeogenesis, leading to increased glucose production. Okay, so he is asking which of the following mechanism is responsible for patient symptoms when exercising. Okay, and in when exercising, hepatic glucose production is going to be increased by, if there is a low glucose, by the glucagon. Okay, now comes to option number B, increased glucokinase activity. Okay, glucokinase is mainly expressed in the liver and is stimulated by rising glucose level. Okay, glucokinase activity is stimulated by rising glucose level, not falling glucose level. Okay, and in this question we are seeing symptoms of hypoglycemia, not hyperglycemia. Okay, increased glucose 6 phosphatase activity. Okay, glucose 6 phosphatase catalyzes the hydrolysis of glucose 6 phosphate to glucose during gluconeogenesis.
Neogenesis.
Okay, thereby helping to maintain the glucose level in the fasting state. Increased activity would improve the glucose level, will improve the hypoglycemic episodes. And we are trying to find in this question who is causing the hypoglycemia episodes. Okay, not the one who is improving the symptoms. Okay, we are going to discuss these in much more detail when we are doing the biochemistry. Okay, which of the following substances is most likely decreased in this patient? Okay, 25-year-old man comes to the physician because he and his wife has been unable to conceive for the last 2 years. They have no children. Okay, infertility evaluation is begun. Okay, a more thorough elucidate a rare gene that leads to permanently inactive FSH receptor. Permanently inactive FSH receptor. FSH decreases what hormone in males? In males, what is the role of FSH in males?
In decreases
Is
inhibin B.
And inhibin B is produced by what cells?
I think it's
Sertoli.
Sertoli cells.
By
Sertoli.
the
Sertoli.
Sertoli cells.
Yeah.
Inhibin B is by the Sertoli cells. And in the question, he has mentioned that the receptors are now inactive. So that means FSH causes the stimulate the Sertoli cells to produces the inhibin B, and inhibin B inhibits the FSH. Okay, so in the question he has mentioned that the receptors which respond to FSH are now inactive, and now because the receptors are inactive in the Sertoli cells, they are no longer going to be produced inhibin B, because they are no longer getting stimulated by the FSH because the receptors are now inactivated. Okay, FSH increases the production of inhibin B. Okay, and LH increases the production of testosterone. Remember this. So what answer it is going to be?
See.
Inhibin B. Okay. FSH has nothing to do with LH. Testosterone is regulated by LH. FSH is going to be increased much more in this patient. Okay. Dihydroepiandrosterone is a androgenic hormone which is regulated by is an adrenal androgenic hormone which is regulated by ACTH.
ACTH.
Let's move on to the next one. Okay. The following is the most likely indication for using this GnRH infusion. Okay, a patient is treated with GnRH infusion into placed. Okay, is delivered a predetermined every 90 minutes. The pump is programmed to deliver a predetermined dose of GnRH every 90 minutes, which results in a sharp rise in serum GnRH levels with each dose followed by a rapid return to baseline. Okay? Okay, this line is very important in this question. LH and FSH levels are monitored in the initial phase of the treatment. Which of the following is most likely indication for using this GnRH infusion? Okay, so we know that we use GnRH in two ways. One is continuous infusion and other is in a pulsatile manner. What is the difference between these two?
Pulsatile will
Pulsatile
stimulate.
for pregnancy and continuous for cancer.
And continuous for cancer, because when you use it in a continuous manner, it is going to act as an antagonist. Okay, act as GnRH agonist when used in pulsatile fashion. Okay, And when used in continuous fashion, first transient act as GnRH agonist, but subsequently act as GnRH antagonist. Okay, in the pituitary. Okay, so because it is used for continuous for cancer and pulsatile for pregnancy fertility. Okay, so what would be the answer here? Infertility, because we are using it in a pulsatile manner. Okay, to mimic the natural body cycles. Okay. A 19-year-old boy is brought to the emergency department due to weakness and confusion. Family members report that for the 19-year-old, weakness, confusion, okay, polyuria, polydipsia, polyphagia, okay, not appendectomy, significant for family history is significant for hypothyroidism in his brother, okay. Blood pressure is 90/60, pulse is 97, patient is lethargic but follows simple commands. Breath has a fruity odor. Okay, the patient is most likely deficient in a hormone that normally performs which of the following functions? Okay,
C.
so so the patient has what?
Decay.
The patient is in decay. The patient age is 19,
Type 1.
type 1. The patient brother has hypothyroidism, which is an indication that most likely the patient also has
Autoimmune.
autoimmune condition. The patient has fruity odor. Why fruity odor? Fruity
TK.
odor is
Ketones.
because it ketone bodies. Okay, and
Acetone.
polyphagia,
Acetone.
polydipsia, and all of these symptoms are of diabetes. Okay, so the patient is in diabetic ketoacidosis. Okay, dehydration, fruity odor due to exhaled exitone. Okay, right. Okay. Now comes iron deficient. The more patient is most in which performs activates the hormone sensitive lipase, decreases the
Decrease
glucagon.
glucagon.
Decrease the okay in type 1 diabetes, which hormone is less? Insulin, right?
Insulin.
Yes, insulin is less. Now we have to tell which is the function of insulin.
Ins-
Okay, insulin decreases the glucose level, right? And it
Yes.
increases the glycogen synthesis, right?
Yes. Increases
Okay.
storage. Yeah.
Yeah. Okay. It so increases hepatic. Which of the that is mostly performed? Which of the following product? Okay. So in liver, it is going to increase the glycogen synthesis. Okay, not the glucose production, right?
Yes.
Yes, it is not going to cause glycogenolysis, but but it is going to increase glycogen synthesis. Okay, increase renal glucose reabsorption. No, it is going to decrease muscle glycogen synthesis. In the muscle, it is going to cause increased glucose uptake. Okay, and in the adipose tissue, it is going to decrease the lipolysis. Right? It is going to
Yes.
decrease the lipolysis. Okay, in muscles.
Yes.
Okay. And how does it work with the glucagon? It counter
Decrease.
regulates. Yeah, they both of them counter regulates each other. Okay, so if insulin is low, you cannot control the glucagon. Glucagon will be high. Okay, but the normal function of insulin is decreasing the glucagon. Okay, which of the following is the primary contributor to the decreased total? See, total three T3 level in this patient. Okay, total three. Okay, total. Okay, free thyroxine is normal. TSH is normal. T3 is low. Okay. And we know T3 is found where?
Peripheral tissues.
In the peripheral tissue.
The words R3 level are increased.
Okay, decreased iodination. Okay, if B is the right answer, decreased iodination of the thyroglobulin. What changes are you going to see in the lab findings?
T4 will be deficient.
T will be low.
Yeah, T4 is also
All
going to
both
be
will decrease.
All
yeah.
will.
Decreased T3 production in the thyroid gland. Does T3 is produced in the thyroid gland?
No.
No.
T4 is produced in the
Yeah.
thyroid and T3 is produced in the peripheral tissue by the conversion of T4. Okay. Same if the iodine, there is iodine the deficiency, T4 is also going to be less.
Yes.
Pituitary resistance to thyrotrophin releasing hormone. Okay, if there's a resistance to thyrotrophin releasing hormone, TSH is going to be very high, and then a no, then
No. All
then
will be
TSH
decreased.
is going to be low, T4 is also going to be low, and T3 is also going to be low. Right? So the right answer is A. The question is, T3 is produced in the peripheral tissues. Insulin. Okay. Downstream function. The T4 is a major thyroid protein to convert T3 in the peripheral tissue to T3 in the peripheral tissue. Okay. The metabolic abnormality most likely responsible for this patient clinical findings can also occur in which of the following conditions? Okay, the patient has progressive lethargy. Okay, 25-year progressive lethargy. Loss of appetite, constipation, muscle weakness, polyuria, polydipsia. Okay. But she takes no medication, but has been taking large doses of vitamin D supplements. Okay, the patient is taking large doses of vitamin D supplement. Okay. The patient is stuporous and has dry mucous membrane. The metabolic abnormality most likely responsible for this patient's clinical findings can also occur in which of the following condition?
I think it's sarcoidosis, hypocalcemia,
Yeah, the patient has all the symptoms of
hypercalcemia.
hypercalcemia. Hypercalcemia. Hypercalcemia. Our patient has polyuria, right? Our patient has constipation, right? Our patient has weakness, yeah, right? Our
Yes.
patient has neuropsychiatric disturbances, right?
Yeah.
Okay. So most of the hyperthyroid is a hypercalcemia symptoms are present in this patient. Okay. Other than in which of these disease you are going to see hypervitaminosis D?
Sarcoidosis.
Sarcoidosis. And how does sarcoidosis leads to hypervitaminosis D?
Because they have
I,
alpha 1 hydroxylase
Alpha
activity
Mhm.
secreted by
And
macrophages.
the macrophages
Secreted by
causes,
macrophages.
yes, the macrophages have has 1 alpha hydroxylase, and they convert the inactivated form into a calcidiol into calcitriol,
Yes.
leading to
Yes.
hypervitaminosis D symptoms. Okay, and then in the question, he has clearly mentioned that the patient that is taking large amounts of vitamin
Vitamin
D.
D.
Which of the following is the most likely mechanism for this patient gynecomastia? See the options. Okay, we see gynecomastia when there is increased estrogens as compared to the testosterone, right? Okay, the patient has headache, loss of libido, erectile dysfunction for the last 3 months. Okay, the patient has no chronic medical condition and takes no prescription or over-the-counter medication. Okay, what is the peripheral vision loss, bilateral gynecomastia, and soft testes without mass, normal serum prolactin, normal beta HCG, low serum LH, low serum testosterone. Okay, which of the following is the most likely mechanism for this patient? Okay, okay, so what is the cause here?
Non-functioning pituitary adenoma.
Yes, the patient has a non-functioning pituitary adenoma leading to hypogonadism. Okay, the patient had headache, peripheral vision loss, that means pituitary is involved. And we can clearly see that there is low LH and low testosterone, and there is smaller testes. Okay, because of the low testosterone. And why there is low testosterone? In the question, he has mentioned low LH. Why low LH? Because low GnRH. Okay, and why low GnRH? Due to the non-functioning pituitary adenoma. Now see what will happen here. Excessive estrogen production in the testes. Okay. Excessive testosterone decrease systemic clearance of. Does it affects anything like the systemic clearance of the estrogen? Does anything happen in the
No.
liver here? There is any abnormality in the liver here? No, right? The
No.
patient is not a liver cirrhosis patient, okay? Because estrogen is cleared by liver. Defective androgen receptor function. If the androgen receptor function is defective, what will happen to the testosterone levels?
Testosterone will increase.
Should be
Yes,
high. Yeah.
testosterone would be high if the main problem is in the receptor, right? Enzymatic defect in the testosterone biosynthetic pathway. If the testosterone biosynthetic pathway is affected, what will happen to the LH levels?
Increase.
Increase.
LH will be high. But what is LH in this patient?
Low.
It is low. Okay. Excessive estrogen production in the testes. Or D, which one is the right answer? D or E?
E.
E is the right answer. Okay. Persistent aromatization of the adrenal estrogen precursors. Okay, because testosterone is no longer producing, and there is persistent conversion of the persistent aromatization in the adrenal glands. Okay, a adrenal glands have produced dihydroepiendosterones, okay, which are estrogen precursors, which are subsequently aromatized to estrogen in the peripheral tissues. Okay, in men with hypogonadism, the resulting elevation in the estrogen to testosterone ratio leads to gynecomastia. The estrogens are normal in this patient. Like if the normal person has a suppose a 10 10 milligram of estrogen, this person has 10 milligram of estrogen, but a normal person has 1,000 milligram of testosterone in the body, but this patient has zero testosterone in his body. Okay, that's why the ratio is tilted towards the estrogen. Okay, even when the estrogens are normal in this patient. Okay, the main abnormality is in the testosterone levels. Okay, which are now zero, which are like zero in this patient. Okay.
Sir, can you please repeat this? I can't get it. Although
Okay.
testosterone is reduced
Okay.
and other options are also incorrect, but what's the mechanism behind this?
For gynecomastia to develop, it depends upon the estrogen to testosterone ratio, right?
Yes, sir.
Okay. So the estrogen testosterone ratio can only be increased either when the estrogen is too high, or the other possibility is when the testosterone is too low, right?
Okay.
These are the only two possibilities in which the ratio is going to increase, right? In this patient, the estrogen is not getting high. Okay, estrogen is the same as in the normal people. The main problem here is that the testosterone is very low here. Okay, that's why the ratio is high here. Okay, gynecomastia.
Sir, gynecomastia will only be occur if testosterone is low.
Estrogen is high as compared to the androgens. Okay,
Estrogen is
our
high.
adrenal glands produces dihydroepiandrosterone. Okay, our adrenal glands produce the androgens. Okay, these androgens are eventually converted into estrogen in our peripheral tissues. Okay, which is a normal thing. Okay, but if your testosterone is too low, you are going to develop gynecomastia. Okay, which is essentially happening in this patient. Okay. Did you able to understand what I'm trying to say?
Sir, a little bit confusion is here. Uh, Testosterone decrease.
Yes, testosterone is low, estrogen is normal, and the overall ratio is high.
Okay.
Okay, testosterone is low, estrogen is normal, and the overall ratio is high as compared to normal. Okay.
Okay, sir. I mean, gynecomastia will only be occur if testosterone is low or estrogen is high.
It
This is the concept.
Yes, it depends upon the ratio. If estrogen is high as compared to testosterone, gynecomastia will occur.
Okay.
Now, then there can be two possibilities. One, that the estrogen is high, or the other is if that estrogen is normal and the testosterone is low. Okay.
Okay.
Which of the following is the most which of the following is the most likely cause of this patient otherwise normal physical examination despite abnormal thyroid laboratory findings? Let's see the question. Let's see the patient. Try to diagnose the patient. Okay, a newborn baby boy is found to have markedly elevated serum TSH and low thyroxine on routine screening. Laboratory finding uses a VNA confirms the diagnosis. Okay. The baby was born at a 39 weeks gestation to a 34-year-old woman who had been taking prenatal. Okay. A, who had been taking prenatal vitamins regularly. No symptoms or abnormal findings on clinical shows an ectopic thyroid gland just below the tongue. Which of the following is the most likely cause of this patient otherwise normal physical examination despite abnormal thyroid laboratory findings? Okay, so the patient has ectopic thyroid tissue, okay, and there is low thyroxine and the TSH is high, but the patient is not showing any signs or symptoms of hypothyroidism. They are asking why this is. Why the patient is not showing any signs and symptoms of hypothyroidism, even when the thyroids, even when the patient has hypothyroidism. What can be the cause here?
Thyroxine is passing from placenta.
Okay, let's see every option. Okay, excessive thyroxine production by an ectopic thyroid. Okay, he is saying excess. Okay, option number A. If there is excess thyroxine, the thyroxine will be high on the routine screening, right? But in our case, in the first line, he has mentioned the thyroxines are
Slow.
low. Increased thyroid binding globulin in pregnancy. Okay, if the thyroid binding globulin will increase, total thyroxine is going to be high, but it will not affect the free thyroxine, and it cannot explain why the patient is not showing any symptoms of hypothyroidism. Okay, transplacental transfer of a thyroid stimulating antibody. If there is transfer of thyroid stimulating antibody, a TSH is going to be low and thyroxine is going to be high, which is not in this patient. Okay. Now, which one is going to be the right answer here?
B.
The
Will
option
from
number
just getting
D.
irritated.
Okay, because the maternal T4 is crossing the placenta. That's why the T4A, the patient is not showing any signs of the hypothyroidism. Okay, because right now in the early months, early few weeks to months, the maternal derived neonatal T4 is enough for the baby. Even when the baby even the baby's itself, the thyroid gland is not producing thyroxine. Okay, the maternally transferred thyroxine is more than enough to cover the during to be able to compensate for whole of the symptom during the first few weeks. Okay, that's why the patient is not showing any signs of hyperthyroidism. Okay,
Sir, why it is not detected in lab test?
why it is not detected in the lab test? I'm also thinking about why the lab test is showing low. Mm. Yeah, why the lab test is showing low? I also
Sir,
don't know why the
sir, if
lab is
T4,
Because of the
if T4,
ectopic thyroid not produce the thyroxine as the normal thyroxine. But the symptoms are not appear because he's getting the thyroxine from the mother maternal thyroxine. There is
That's
a
the
less
question.
amount, but it's not now cause the symptoms. It cause subclinical hypothyroidism.
but why there is low thyroxine?
Because
Because the
because
This
in lab
thyroxine, the thyroid gland not producing the neonatal child, the thyroid gland not producing the thyroxine.
He is asking why the routine screening is not detecting the maternally transferred thyroxine. His question is that why
That's
the
not
routine.
enough to increase the thyroxine level. Actually, the symptoms are not being appeared just because the thyroxine is being shifting from the placental route. And the ectopic thyroid always show the hypothyroid signs and symptoms because of the low production of thyroxine.
So that's one thing, and also calculate the T half, right? It's a hormone. Obviously, it will have T half. After some time of delivery, the baby is not getting it from mother. It can't produce its own to the sufficient amount. So T half nahi hote, so they can't find it right in tests.
Okay. Okay, so the amount of neonatal T4 is still low compared to that in unaffected patients, but it is sufficient to initially prevent the clinical manifestations of hypothyroidism. Okay,
Yeah,
Mhm.
this is
T4
what
is
I am
still
telling
So
that
this is the
this is
explanation, yeah.
yeah,
subclinical hypothyroidism.
yeah,
Yes.
but it
Now,
is still sufficient to prevent the clinical manifestations of
Manifestation.
hypothyroidism.
yes,
Okay. Okay, and that T4, which this neonate is, that all has came from the mother. Okay, which is still low, but that is sufficient enough to prevent the clinical symptoms in the initial days.
Baby.
Okay, so that's the reason. Okay, which of the following hormone is most likely elevated in this patient? Which of the following is most likely? See the options. 50-year-old woman comes to the office concerned that her menstrual periods have stopped. She takes OCPs for the past 17 years, which she discontinued 3 months ago, and her menses have not returned. The patient had one spontaneous abortion at age 72. Okay, she's monogamous with her husband and they have sexual intercourse regularly. The patient has some vaginal dryness, but no pain or discomfort with intercourse. BMI is 21 kg per meter. Okay, vital signs spec shows a normal vaginal mucosa and cervix. Okay, urine pregnancy test is negative. Okay, so the patient is showing signs of what? She's a
Menopause.
50
Menopause.
year
Menopause.
old woman, which has no. The patient is in menopause.
Menopause.
Okay, and in menopause, which hormones are going to get elevated?
FSH.
FSH and LH.
FSH.
FSH, LH, G, and RH, and which one are going to be decreased?
Estrogen.
Estrogen.
Estrogen is going to be decreased. Okay, yes. So the right answer is going to be FSH, right?
Because it is markedly elevated. It is the marker of the menopause.
Yeah, because there is no longer estrogen production, so the body, so the pituitary will increase the production of FSH.
There's inhibition of negative feedback.
Yes, I'm trying to find out where it is.
Page 653.
Page is on here.
653.
Yeah. Hormonal changes, estrogen decreases, FSH markedly increases, LH increases, GnRH increases in menopause. Okay. Markedly is specific for the menopause due to loss of negative feedback on FSH due to decreased estrogen. Okay. Which of the following changes addition is most likely to be seen in this patient? Okay, worsening generalized weakness, myalgia, unintentional weight loss. The, she has primary hypothyroidism as well. Okay. So whenever you see this line, the first thing that should come inside your mind is autoimmune condition, some autoimmune condition. 90% of that line means that the patient has some autoimmune condition. Okay. Blood pressure is 110/70. Okay. The patient has postural hypotension as well. Okay. She is mildly emaciated. Okay. Mild normocytic, normochromic normocytic anemia. Eosinophilic count is 15%. Serum glucose is also low. All of these signs and are signs and symptoms of what disease? Posture,
Ad-
hypertension,
Low
weight
Adrenal
loss,
insufficiency.
myalgia,
adrenal insufficiency.
adrenal
Adrenal
insufficiency.
insufficiency.
Most common cause of
Adrenal
adrenal
insufficiency.
Autoimmune
insufficiency.
types.
Autoimmune destruction.
Adenoma.
Medicines.
Adenoma.
Medicine.
Is autoimmune condition. Okay, the most
Primary
common
Autoimmune.
reason.
primary is
Yes.
autoimmune.
Okay, and what will happen to the eosinophils in the adrenal insufficiency?
Increases.
Increases.
Yes, they are going to be increased. Our patient has weight loss, muscle aches,
Hypokalemia.
fatigue, orthostatic hypotension. Okay, okay. Because in adrenal insufficiency, both the cortisol and the aldosterone are going to be low. Okay,
Decreasing.
what is the effect of cortisol on the eosinophils? That cortisols are going to increase when the cortisols are high.
Decreased.
Yeah, eosinophil is going to be low. Okay, so when the cortisol is low, eosinophils are going to
High.
be high, right? That's why we use steroids in the asthma, because that reduces the eosinophils. Okay. You can also say most commonly due to autoimmune adrenalitis in high income countries. Okay. Okay. Now we have to tell what are the findings here. What will happen to the potassium level?
Increase.
Hyperkalemia.
Hyperkalemia.
High.
Aldosterone is low, then hyperkalemia.
And what will happen to the urine potassium levels?
Urine
Decrease.
decrease.
Low.
Decrease.
Low.
Okay, so there's
Low.
only one option which has high,
Serum
low.
sodium
Yeah.
Serum sodium will be low, urine sodium will be high.
high.
See, hyperkalemia, metabolic acidosis, hyponatremia. Okay, let's move on to the next one. Poor feeding, lethargy, unusual muscle movements involving the left thumb and hand over the last 2 days. Okay. Infant's vital signs are normal, but unusual flexion. What is the name of this sign? Unusual flexion of the left wrist and thumb, and extension of the fingers with tough blood pressure manner.
Trusier sign with
Tourette.
hypocalcemia.
Trozo.
Hypocalcemia sign is the Trusier sign.
Yes. Okay. Physical examination shows hypoplastic mandible, low set ears, biped uvula, and cleft palate. Chest
What?
X-ray reveals decreased soft tissue attenuation in the right and right mediastinum.
Mm.
The George.
The George.
There is no any disease. In this, there is hypokalemia, hypocalcemia, cleft palate, hypoplastic mandible, low set ears, and the chest X-ray. Can you tell me which structure is present in the anterior mediastinum?
Thymus.
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 So he is telling the patient has no thymus, right? So do you know any disease which has all of these features?
The George.
The George. The George.
George. Okay, very good. George. Truce sign, occlusion of the brachial artery with big tufts, carpal spasm. Okay. Okay. And it occurs, hypoparathyroidism can occur in George syndrome. Okay, George syndrome is explained in the endocrinology. George.
Hypoplastic mandible, low set ear, 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 hypoplastic mandible.
Miss Kumari, your mic is on. We could hear everything. I don't understand it, but we could hear everything.
Okay. Okay, George syndrome. It occurs due to 22q11 microdeletion, failure of what pouches? Third and fourth. Okay, absent thymus and parathyroid. The CAS 22. Abnormal faces. Does our patient has abnormal face? Does our patient has
Yes,
abnormal
perfect.
hypoplastic mandible?
Yes, yes.
Low set ears, bifibula. Okay. Does our patient has cleft palate?
Yes.
Does our patient has thymic hypoplasia?
Yes.
Does our patient has hypocalcemia?
Yes.
Okay, so all of these signs are indicating towards the George syndrome. Okay. Okay. Now
So
comes to the
specify which one, the third or the fourth, because in one of the question they specifically ask either it's third or the fourth pharyngeal pouch.
in this question they are asking which one is absent here. There is no fourth here.
Third, it's the third.
Third is the more specific because third
Not
T
the
for
fourth.
third, T for thymus.
Okay. And the in this question, which one is going to be the answer? Third pharyngeal pouch. E is going to be the answer, right? Because parathyroid gland and the thymus, both of them develop from third, and from the fourth, the parathyroid gland superiors are developed. Okay. Let's move. Which of the following factor is most primarily responsible for this patient increased frequency of hypoglycemia? Okay, the patient has type 1 diabetes since age 12. Okay, and it is diligent in taking insulin to achieve normal, good glycemic control. Over the past few months, the patient had more frequent episodes of hypoglycemia. Okay. Okay. A physical examination is unremarkable, but the episodes He had more with despite no changes train. Episodes have been associated with less severe hypoglycemic symptoms compared to prior. Okay. Laboratory results shows normal basal metabolic plane. Hemoglobin A1C is 7.0 is primarily responsible for these patients' increased frequency of hypoglycemia. Okay. Which of the following is responsible for increased frequency of hypoglycemia? The patient has type 1 diabetes, right?
Yes, since 10. Well,
Application of vitamin energy type 1 is okay. So the patient has type 1 diabetes since age 12. Okay. And the age of patient is right now is 34. Okay. Down regulation of insulin receptors with a no. Option number D, chronic exposure to high insulin can lead to down regulation of insulin receptor and reduced insulin sensitivity. Okay, and this effects promotes hyperglycemia. Okay, not hypoglycemia, right? If the receptors are down regulated, you are going to see more hyperglycemia symptoms, right?
Like type 2 diabetes.
Yes. Okay. Upregulation of beta adrenergic receptors. Okay. Okay. The increased beta adrenergic receptors will increase the will
glucose.
reduce
insulin.
because in
Epinephrine will act more, so gluconeogenesis will be increased, more glucose.
yes, which generally and upregulation will increase the awareness, right? And in this patient, awareness is reduced, right? Now comes to option number C. A growth hormone is very less important in controlling the in preventing the hypoglycemia, right?
Yes.
Okay, decreased epinephrine release. Now we are left with A
Sir,
and C.
why E option is not correct?
If the adrenergic receptors are upregulated, what will happen? The awareness is going to be increased, right? Right? Upregulation of betas will generally reduce the hypoglycemia and increase the awareness. Okay, but in our case, we are seeing decreased awareness and increased hypoglycemia. Okay. Okay, now comes to two options, A and B.
B.
Decreased glucagon release will lead to increased hypoglycemia. Decreased epinephrine will lead to increased, it will lead to decreased hypoglycemia awareness, but they are less important than glucagon in regulating the glucose levels,
Yes,
right?
chronic inhibition will decrease glucagon.
Yeah. And in type 1 diabetes, when there is low insulin, that in after a very long time period, you will also see alpha cell failure as well. Okay, in type 1, there is very high chances of after a long standing diabetes that there you are going to see alpha cell failure. Okay, and due to which you are going to see more episodes of hypoglycemia. Okay, this is called pancreatogenic diabetes. Okay, and it is due to the inadequate alpha cell reserves. Okay, and it occurs because of the there is decreased insulin, and that due to which the cells try to produce much more, the cells produces much more glucagon. Okay, but eventually the cells are going to, that increased working of those cells lead to failure. Okay, let's move on to the next one.
Doctor, why not A is the right answer?
Because A does reduce the hypoglycemic awareness, but it is not as important in the in causing hypoglycemia as compared to glucagon. Okay, that's why A is not the right answer. Okay, A option number A can explain the decreased hypoglycemia awareness, but it cannot explain the hypoglycemic episodes. That they because in increased number of hypoglycemia episodes, glucagon is much more important as compared to epinephrine. Okay. Which of the following is the most likely cause of the patient's abnormal thyroid function test? Okay. A 1 week old newborn is seen for abnormal thyroid function test. The free T4 is normal. TSH is normal. Total T4 is abnormal. Okay, total T4 is low. What can be the cause that of the total T4 is low? Okay, option number A, hypopituitarism. No, if there is hypopituitarism, TSH is going to be low. Option number E. If E is the right answer, T4 is going to be low and
Decrease, yeah.
TSH is going to be high. Decrease T4 conversion to T3. Okay.
T4 will be high.
Yes. Okay. Now comes to the and that cannot also explain the low T4, total T4. Okay. Deficiency of thyroxine binding globulin and hypoalbuminemia. Which one is going to be the right answer?
B makes more sense.
B is the right answer because in the transfer of thyroxine, albumin is not involved. Thyroxine binding globulin is involved. And we know the total T4 depends upon the bound,
TBG.
thyroxine molecules. Okay. That's why the total depends upon the bound thyroxine. When the protein is low, the total is going to be low, but the free is going to be normal.
Is opposite in pregnancy, yeah, same like.
Okay, antibodies against thyroid peroxidase are present. Okay, now you have to tell me which one is the function of thyroid peroxidase.
This is like
Iodination coupling.
Hashimoto's, yes, of the
Iodination.
organization.
Iodination coupling.
Coupling,
Organification.
organification, both.
What is the normal value of free T4?
Normal value, wait.
It looks like
Thyroid.
T4 is decreased, but what's the normal?
Thyroid peroxidase functions: oxidation, organification, and coupling. There are three functions: oxidation of iodine, organification of iodine, and coupling of monoiodotyrosine and diiodotyrosine. Okay, these are the three functions of thyroid peroxidase. Now see, Which one is going to be the right answer here?
C.
C is going to be the right answer. Okay. Thyroid peroxidase is involved in iodination, coupling, and organification. TSH values. Zero 0.424, and in our patient was the value was 3. 3, that was normal. Failure of which of the following embryological process is most likely responsible for this patient lesion? Okay. Okay, so the patient, a 13-year-old boy, is brought to the clinic due to progressive difficulty with breathing, hoarseness, and dysphagia. Okay, the symptoms begin insidiously 6 months ago, but have rapidly become worse in the last 4 weeks. The patient has no associated skin rash and pharyngeal pain, fever, weight loss, or loss of appetite. Medical history is unremarkable. The patient's parent and siblings have no history of significant health problems. Okay. Large red lingual mass. Okay. So this histology picture is similar to what?
Thyroid tissue.
Thyroid
Thyroid
follicle.
follicle.
Yeah, it is similar to thyroid follicles. You can see the colloid pink material and then the thyroid follicle cells. So the patient here has what problem?
Lingual thyroid.
Migration.
Yes,
Migration has,
ectopic.
Migration.
he has an ectopic thyroid tissue. Okay.
Migration.
And the most common present of a position of ectopic thyroid tissue is tongue. Okay, so the patient has lingual thyroid tissue. Okay, see this photo. Colloid, perifollicular cells, epithelial cells. Okay, this is a normal histology picture of a thyroid. Okay. Okay. So what will be the answer here?
D. Migration.
Migration. Okay, so there's an abnormal migration due to which the thyroid tissue remain at the lingual area and does not move in front of the thorax, in front of the neck area, in front of the vocal, the larynx. Okay. Which additional findings will most likely to be present in this patient now compared to 6 months ago? There is a 16-year-old boy, irritability, slow growth, acne, play soccer, strength training program, admits to using performance enhancing drug for the past 6 months. What will happen to the findings? Okay. androgen embolic steroid use. Okay. Decrease the intratesticular testosterone production and decrease testicular size, sperm count, azoospermia. Okay, and we have to sing hirsutism, acne, breast atrophy, androgenic alopecia. Okay. So what will happen to the spermatogenesis?
Decrease.
That will be
Low.
decrease. What will happen to the serum LH? What will happen to
Everything.
the
So
LH? Why it is going to be low?
Because
negative
the
feedback.
exogenic testosterone he taking and the negative feedback,
Yes, the
after
patient is
testosterone.
taking steroids, right? Okay. What will happen to the serum estrogen?
High.
Increase.
Why?
Conversion of testosterone to the estrogens by aromatase.
Yeah, by aromatization in the peripheral tissue. Okay. Okay. Very good.
So, doctor, there is no testosterone, then
In the
negative feedback.
intratesticular testosterone, there is no intratesticular testosterone. There is testosterone here. The intratesticular testosterone is not present here.
Okay, so testosterone will be there.
Yes, the patient is the patient is taking androgenic steroids.
Sportsman's bodybuilder, they are taking exogenic
Yes.
testosterone to increase the muscular mass, to increase the strength, in aerobic exercise.
So estrogen is increased because the testosterone is converted into estrogen. So exogenous testosterone is taking.
Yes, yes, because of the peripheral conversion of the increased testosterone into increased estrogen. Okay, because
Okay.
when the bodybuilders usually take that steroids, they are taking in a much more higher amount as compared to the what that is produced in our body. Okay, so when there's
And
increased testosterone, you are going to see increased estrogen. Okay.
so doctor, LH is low because there is a negative feedback.
Yes.
So what is the difference between intratesticular testosterone and
Intratesticular gas is produced by the testes.
Yeah, and the one he is taking it is exogenous.
so this is also produced by the testes? Oh, okay, LH said.
No, I don't get your question.
Sir, my question is that what is the difference between intratesticular testosterone and this testosterone? Exogenous.
Usually, they are androgenic compounds. They are similarly their structures are similar like testosterone. They are not like exactly the same like testosterone. Okay, because there are different compounds which are come there trenbolone, and there are different types of compounds which were used by the bodybuilders and all the other professionals. But they are not exactly the same like the testosterone, but they are
So
from the same family. Okay,
so it
they are
can
from
say
the same family of the androgens. Like
so
we
that
use the dexamethasone. Dexamethasone has the same effect on the pituitary as the cortisol. Okay.
okay. So doctor, we can say that it only performs the function of the peripheral conversion, but the
Yes.
actual functions of the testosterone all are suppressed.
The actual function will all of them are going to be increased, other than the function which is happening in the testes. Okay. All of the
Yes.
other functions are going to be increased. The balding is going to be increased. The muscle protein synthesis is going to increase. The muscle mass is going to be increased. All the other functions in the body are going to increase. The blood pressure is going to increase. Aggression is going to increase. Okay, let's move on to the next one. So
Okay,
this is
okay.
the last question of the anatomy, physio, and the embryology of the endocrinology. Okay. Now only the miscellaneous questions of the endocrinology are left. I think so. There are about 25 to 30 questions. Okay. Which of the following endogenous substances best explain the difference between the curves? Researchers made the serum insulin levels of the healthy interval volunteers after equivalent dose loads of oral and intravenous glucose. The following curves are obtained. Okay, so in one, when you give the intravenous glucose, there is a much low increase in the insulin levels as compared when you give oral glucose. Why?
Due to secretion of glucagon-like peptide 1
Peptide.
from the
Glucagon-like peptides are released only when there is oral consumption of glucose. Okay, so they are not going to be released when you are give to it when you give the glucose IV. Okay, that's why there is a less spike in the insulin when you give it IV. Okay, because glucagon like peptides are not released. Okay, because they are released only, they are
Liver.
gastrointestinal hormones produced by the gut mucosa. Okay, they are produced when you take the glucose through a meal. Okay, in your digestive tract. Okay, the answer is glucagon like
Somebody
peptide.
mentioned in text is incretins.
Yes,
Doctor, I think
incorrect. Yes.
answer
Okay,
very
They
short.
also
so
inhibit glucagon.
yeah, okay, I will make another block.
Doctor, can you explain the previous one of the testosterone? The answer is E or the B?
The answer is E. Serum LH is low, serum estrogen is high, spermatogenesis is low. Okay.
Thank you.
Spermatogenesis is low and also LH is low.
Yes. Spermatogenesis is low because the intratesticular testosterone is low. And the LH is low because the androgens in the bloodstream is high. Okay.
Okay.
Okay. Anatomy. We have done with anatomy. Biochemistry. Biostat. No. Genetics. Histology. Immunology. Microbiology. Okay, of endocrinology. So there are 25 questions. Okay, if I select the behavioral and the biostat as well, the questions will increase to 26. Okay. So there are 26 questions total. And most of the questions are of biochemistry. Like 22 questions are from biochemistry and the rest are from all the other topics. So do you want to do biochemistry now or do you want to do biochemistry when you people do biochemistry? Because mainly the questions are from biochemistry. You are going to see vitamin diseases, maple syrup urine diseases, phenylketonuria. What do you
Yeah,
people want?
I think when we do the biochemistry, then we can.
When we do the biochemistry.
Okay, so the rest there are only 3 questions. If you want to do only the other ones. How many questions? There are only 3 questions.
After.
Endocrinology.
Doctor, we will be moving systematically, I mean subject wise.
Yes. There's only 3 questions here. Yes. After this, we are going to start a renal system, because you people have already covered the renal and the cardio system, right?
Yeah, but can we do immunology first?
We will do immunology with system wise, like we did the immunology of the respiratory system. Now we will do some questions of the endo section, and then with each system we are going to cover their immunology. In this way it will be much more easier to understand the immunology. Okay, and in the end we will cover the remaining questions of the immunology. Okay, but if you do the immunology system wise, that will be much more easier for the immunology. Okay. Okay, I'm sharing my screen. Which of the following interventions is likely to have greatest effect on the reducing this patient mortality risk? Okay, it is a question of the biostat. Okay. Let's see if people are able to do this. 50-year-old who completes the 25 years of if you people want, we can do the biochemistry questions as well. If you people want to. Okay. He has a 20-pack year smoking history and consumes alcohol occasionally. He eats a balanced diet and consumes fried foods and red meat several days.
We can't see your screen. Huh?
You people can't.
We
We
can
can
see.
see screen. We can.
Yeah, I think so. I'm
I
sharing
think
my screen. A 50-year-old man comes to the physician for a routine checkup. He has a 20-pack year history. It's a balanced diet. He is not very active and spends much of his time working. His family history is significant for hypertension in his father, blood cancer in his brother. Okay. His blood pressure is 160 by 90. Heart rate is 70. He has 20 years smoking history, consumes alcohol occasionally. Okay, balanced diet, consumes red meat, is not very active. A lot of risk factors are present here. And there is blood glucose level of 155. Which of the following intervention is likely to have greatest effect on reducing the patient mortality risk?
Smoking cessation.
Okay.
I think
Smoking cessation.
smoking is a big factor.
Smoking cessation.
Okay, why not tight glycemic control?
In
Why
literature,
not
now
tight?
not recommended tight glycemic control because it's also is cause some complication of hypoglycemia, and it's proved that tight glycemic control not
And smoking is
decrease
the
the
number one cause
mortality.
factor of the ischemic heart disease also.
Yes, smoking is the number one risk factor for the MI. And in the
Ischemic heart
diabetes
disease.
patients, yes. Yeah, and the diabetes, the most common cause of death is
MI.
MI, right? And the smoking
Silent
MI.
cessation
MI.
is the most, yeah. And I want to confirm one more thing, that the tighter glycemic control, I think so, does not prevent macrovascular complications. Determinism. Okay. MI is the most common cause of death, and And tighter glycemic control does not prevent the macrovascular complications. Okay, remember this. Okay, it can reduce the microvascular complications. You will see a question on this in your step 2. So remember, microvascular complications like retinopathy and the nephropathy and neuropathy can be controlled by controlling the glucose. Okay, by getting a tighter glucose control. But the macrovascular complications cannot be controlled by controlling the glucose. Remember this. That's why MI cannot be controlled by option number G. Regular exercise, okay, that can reduce, but it is not the greatest. The diet is already very good, okay. No prostate cancer, no occult, no smoking cessation, very good. Okay, you can see smoking cessation has the highest. Okay, residual risk, smoking cessation. After that, aspirin therapy and lipid reduction and blood pressure control. Okay. These cells are most likely be directly activated by which of the following substances? Okay. So this is the photo of adrenal gland.
Gland.
Yeah.
Medulla,
So,
adrenal medulla.
Arrow
so
showing the
the
medulla. Yes.
So the layer is shown that is indicating there are first 3 layers, glomerulosa, then the fasculata, then the reticularis. Okay, after these 3 layers, the 4th layer is medulla.
Medulla.
And the medulla is stimulated by what? Now we have to tell medulla is stimulated by what?
Acetylcholine.
No, epinephrine, no epinephrine. But
Epinephrine and
It's
norepinephrine
accredited.
are the
Accredited
products which are produced
products.
by
Yeah,
yeah.
they are produced.
And if you ask
Acetylcholine.
me yeah, the pre-ganglionic fiber of
Yes.
Acetylcholine.
of the sympathetic nervous system secretes what? They
Only
secrete
acetylcholine.
acetylcholine. Okay. Okay. So the pre-ganglionic. Okay. Which of the following is most likely case of this patient condition?
sir, what was the concept? The preganglionic fibers of the
Sympathetic nervous system. Of the sympathetic nervous system. Okay. They secrete what?
secret acetylcholine. Preganglionic fibers of the
Yes.
sympathetic nervous system.
Yes, because the preganglionic comes into the adrenal medulla, and the adrenal medulla act as a postganglionic nerve. Okay, and it secretes the norepi. Okay. To find that, you'll find it later. So let's move on to the third one. Which of the following is the most likely cause of this patient condition? Okay, 2-month-old boy, floppiness, poor feeding. Okay, good boy who rarely climbs sleep through the night but has been difficulty to rose for breastfeeding. Stools have also decreased to every okay and are small and pellet-like. Hypotonic infant with large anterior fontanella, large tongue and large and reducible a umbilical hernia. He has a low tone, unable to hold his head erect on his own. Okay, so all of these are signs of cretinism, right?
Congenital hypothyroidism.
Okay. Pot bellied, pale, puffy faced. Our patient has protruding umbilicus as well, and protruding tongue as well. And okay. So what would be the diagnosis here?
Hypothyroidism.
Hypothyroidism.
Hypothyroidism. Okay. Okay, the patient has cretinism, hypothyroidism. Okay. So our endo is finished, except for the biochemistry part. The biochemistry has 23 questions. Okay. So after this, we are going to start renal. I am going to make a poll in the group to you people. Let me know, do you want a lecture on Sunday or not? Okay, because we skipped one lecture on the Friday. Okay, I will make a poll on the in the group. Okay, okay, and you people will let me know whether or not you want the lecture on Sunday. We will start renal on Sunday. Okay.
Excuse me, sir. I'm
Yes.
new. I joined today. Actually, I want to talk with you, but I don't know how to approach you.
Okay, you can approach the one who has sent the group in the who has sent the link in the group. Okay, Dr. Ahmed has sent the link in the group. You will you can talk to her. Okay.
Okay.
Okay. And the ones who still didn't pay, from the next week, we are making a change that the ones which have already made the payment will get all the lectures for all the days in the week, and the one which didn't pay will get the lectures only for Monday and Tuesday. Okay. Okay. So that's all for today. Okay. Bye bye. We will going to start a renal. Okay. Okay, from tomorrow or from Monday, I will create a poll in the group. Okay, just let me know whether or not you people want a lecture tomorrow, or do you want to catch up. Okay. Okay. Bye bye.
Thank you.